Fine, good morning to everyone. Thank you for such kind introduction. Um, Today, I would like to take this opportunity to present my case report, which is basically a case of a cardiac tamponade in a young female who presented with a primary hypothyroidism. In this case, I am going to discuss not only with the presentation, but also how do we manage the case and what are the various approaches to prevent the recurrences. And this is our prestigious Osmania General Hospital, which is located in the beautiful city of Hyderabad. It's a century-old hospital where I am doing my cardiology residence right now. And these are my acknowledgements. I would like to take this opportunity to thank my HOD, head of the department, as well as the Professor of Cardiology, Dr. KMK Reddy, and my assistant professor, Dr. Praveen Nagula, and my colleagues who contributed a lot and for the encouragement for this case report. And there are no conflicts of interest to declare. And this case report has been published after obtaining the informed consent from the patient. Before going to the actual case details, I would like to discuss what are the usual manifestations with which a patient with hypothyroidism presents. As you all know, hypothyroidism is the most common endocrine disorder worldwide, but still it is more prevalent in India, mainly from the iodine deficient regions. It is more common in women, especially the prevalence increases as the age progresses. The various manifestations of hypothyroidism are basically the result of hypometabolism at the cellular level and almost affects every organ in the body. So according to the thyroid registry in India, which has been published in 2017, the most common signs and symptoms of hypothyroidism includes the lethargy, which is most prevalent of all, followed by weight gain, alopecia, psychomotor retardation, constipation, dry skin, cold intolerance, hoarseness of voice, as well as the bradycardia. Apart from this, the cardiovascular manifestations do occur in hypothyroidism, where asymptomatic mild pericardial effusion is quite common, accounting for about 3 to 6% of cases. But cardiac tamponade, presenting mainly as a feature of this hypothyroidism, is quite rare. And our case report mainly concentrates on this type of presentation, where a young female who diagnosed with primary hypothyroidism presented with cardiac tamponade rather than other manifestations of hypothyroidism. Going to the case details, a 20-year-old female who presented with the complaints of breathlessness for the past 6 months. She progressed from New York Heart Association class 2 to class 4 from 1 month prior to the admission. There was history of lethargy and constipation initially before 1 month of her presentation to our department, for which she consulted a primary physician and a diagnosis of primary hypothyroidism. She was prescribed levothyroxine 50 micrograms, and she was found to be non-compliant. She was born out of a non-consanguineous marriage. Her birth history was uneventful, and there was no any developmental milestone delay during her infantile age. She attained menarche at 14 years of age. Irregular cycles were observed at the time of puberty. Still, at the time of presentation, she is having irregular cycles. She is the youngest of her 4 siblings. Her eldest sister was also diagnosed to be having hypothyroidism before 3 years, and she was kept on levothyroxine 25 micrograms. There was no history of any other drug intake, like she has not taken any antithyroid drugs during her past 2 to 3 years. After obtaining the history, we thought of examining the patient on general examination. She was conscious, coherent, and she obeys verbal commands. She had a pallor, and her weight was 22 kgs, and height was 130 centimeters, which accounts to BMI of 13 kg per meter square. And BMI of this category usually falls under underweight as per the both world as well as Asian classification of BMI. And her arm span is equal to height, whereas upper segment is equal to lower segment. She had a coarse dry skin, it's a loss of hair, that's alopecia with hoarseness of voice. She had cold peripheral extremities, hypertonia. There was a proportional skeletal immaturity, and no secondary sexual characters were also there. She had a peculiar dysmorphic faces, which is very unique to this case presentation. She had a puffiness of the face with periorbital swelling with widened nasal bridge. The face was leptoprosopic, which with a facial index of 92%, and dolichocephalic with a cephalic index of 72.9%. On examination of oral cavity, she had a good hygiene, but there was a mixed dentition with multiple retained deciduous teeth. This slide explains what is facial index and what is cranial index. Facial index is nothing but it is the ratio of the morphological facial height to the bizygomatic width. If it falls between 80 to 84.9%, we call it as pseudoprosopic, and 85 to 89% we call it as mesoprosopic, and as in our case where it is more than 90%, we call it as leptoprosopic. Just like facial index, cranial index is the index which predicts the shape of the head. It is a ratio of the maximum skull width to maximum skull length into 100%. Dolichocephaly is nothing but the long, narrow, tall head as in our case, whereas the brachycephaly is a wide, shorter head. This is our patient. She had a the picture depicts the short stature. She had a proportional skeletal immaturity, and there was a loss of hair. There's alopecia both in the frontal and temporal region, and she had a flat faces with leptoprosopic face. On systemic as well as the vital data examination, she had tachycardia of 130 beats per minute with hypertension of 90/60 millimeters of mercury. She was tachypneic with a respiratory rate of 26 per minute. Her SpO2 was normal at room A, and she had elevated JVP of 12 centimeters of water with a prominent X-descent and absent Y descent, which is very typical JVP manifestation of cardiac tamponade. And on auscultation, there were distal heart sounds were heard. Other rest of the respiratory, gastrointestinal, neurological systems were normal. And after opening the entire case, I would like to summarize my case. She's basically a 20-year-old young female with New York Heart Association class 4 dyspnea with a history of constipation and lethargy. And she was diagnosed to be hypothyroid before 1 month, but she was found to be drug non-compliant. She had a peculiar dysmorphic faces with irregular menstrual cycles with a classical Bextroid, which points us to cardiac tamponade like hypotension, elevated JVP, and muffled heart sounds with clear lung fills. With this background, we thought initially it's a case of cardiac tamponade, and probably because of her 1 month history of hypothyroidism and clinical features, we thought it could be secondary to the hypothyroidism. Accordingly, we thought of evaluating the case. Before going into the investigations, we kept some of the differential diagnosis in our mind. Tuberculosis is still a wide prevalent problem in India, so it's a great massacre of many diseases. So it was our first reading. And secondly, we thought it is a congenital hypothyroidism. It can be primary, secondary, or peripheral, and it can be it could be like primary hypothyroidism due to iron deficiency, secondary hypothyroidism, or connective tissue disorders. So we thought of evaluating the case so that we could reach a cause of cardiac tamponade. So once we obtain the history, I would like to pose a question: why could it not be a case of congenital hypothyroidism? Since we had the history from the mother as well, there was no history of any developmental delay or mental retardation, feeding difficulties, lethargy or constipation, and prolonged jaundice during her infancy. And she had no macroglossia or umbilical hernia. So with this history as well as the physical examination findings, we thought of safely excluding congenital hypothyroidism as a probable entity. Then we subjected the patient for the immediate chest X-ray PA view, shows a classical picture of massive cardiac cardiomegaly, such of cardiac tamponade with a typical water bottle configuration, and her lung fills were normal. Bedside electrocardiogram revealed sinus arrhythmia with low voltage complexes and classical electrical alternance. There is a varying morphology and amplitude of this QRS complexes, which is quite evident in this ECG. And this is a classical two-dimensional subcostal four-chamber view showing the signs of cardiac tamponade. The most sensitive sign which is shown here is that there's a collapse of the free wall of right ventricle during the diastole. It itself indicates that intrapericardial pressures or exceeds the right ventricular filling pressure. It is one of the sensitive signs of cardiac tamponade. So since cardiac tamponade is emergency, rather than evaluating the case, we thought of initially managing so that her life could be saved. So we thought of, we immediately aspirated 1,000 ml of straw color fluid by emergency pericardiocentesis. There was a dramatic improvement both hemodynamically as well as clinically. And there was a resolution of tamponade, which is evident on the bedside 2D ecography. Initially, after initial pericardiocentesis, we kept the pigtail in situ so that if there is any reaccumulation, we thought of aspirating. On second day, again, there was 1,000 ml of fluid, which was aspirated with pigtail, and then pigtail was removed. And after the second day, this X-ray was obtained, which shows the considerable decrease in cardiomegaly. This X-ray was taken after the pigtail is removed. So post-pericardiocentesis ECG showing there is a regaining the voltage of the QRS complexes with loss of QRS alternance. There is no electrical alternance which is evident, though there was a mild tachycardia of around 100 beats per minute. And then we subjected this fluid for analysis. We show that the protein count is elevated, which is classical of exudate with a slightly elevated blood sugar levels. Acid phos bacilli and ADA levels, that is adenosine DMA levels, were normal, and AFB is found to be negative. So with these two taking into consideration, we excluded tuberculosis as one of the probable cause of this pericardial effusion tamponade. And microorganisms were found to be negative on blood cultures, on pericardial fluid culture. And microscopy revealed a lot of lymphocytes with cystic macrophages and degenerative cells, suggestive of an exudate. And cell block was negative for malignancy, so even the malignancy was excluded from this pericardial fluid analysis. So from this, we excluded tuberculosis as well as the malignancy as a probable etiological diagnosis of cardiac tamponade. Now we subjected the patient to the biochemical profile. We show classical features of hypothyroidism, primary hypothyroidism, like low T3 and low T4 levels with elevated TSH of more than 100 millionewton units per liter. And she had mildly elevated cholesterol as well as the triglycerides levels. And these mainly because hypothyroidism is one of the most common cause of secondary dyslipidemia, which was evident even in our case also. And glucose is also mildly elevated because hypothyroidism do cause insulin resistance, so which cause hyperglycemia. Growth hormone is found to be normal. So since the growth hormone is normal and TSH is more than 100, we excluded the secondary hypothyroidism as the cause of this cardiac tamponade. And serum calcium phosphorus and alkaline phosphorus levels were found to be normal. They're all within the normal range. She had anemia 7.8 gram per deciliter. That is, again, it could be because of hypothyroidism, because it's one of the most common cause of anemia of chronic disease. So when we subjected the blood for peripheral smear, there's a classical normocytic normochromic RBCs, which is very typical of anemia of chronic disease. And since she's a young female with a peculiar dysmorphic features, we thought connective tissue disorders could be a possibility. So we subjected the patient for quantitative ANA levels, which was found to be negative. Her basal metabolic rate was found to be low, like 1040 kilocalories from her past 2 days diet. And ultrasonography of the thyroid revealed it was a normal in size with normal ecotexture and vasculature. Even it excludes the congenital hypothyroidism, because the most common cause of congenital hypothyroidism is ectopic thyroid or thyroid dysgenesis or agenesis. So even we excluded the congenital hypothyroidism. So after all these investigations, the only thing we left is with the diagnosis is a case of primary hypothyroidism, probably secondary to the iodine deficiency. So we thought of evaluating the patient because of peculiar dysmorphic features. So we subjected the patient for the X-ray skull. It is shown in the picture that both AP and as well as the lateral view of X-ray skull shows incomplete apex closure with multiple unerupted and residual permanent teeth. There are also a classical delay in the closure of coronal, sagittal as well as the lambdoid sutures. Now, again, because of her short stature, we thought of evaluating her bone age. Usually, the bone age which should fall within 10% of the chronological age. Here, her chronological age was 20 years. So, we thought of ordering the patient for X-ray left-hand AP view of wrist. We showed the delay fusion of epiphysis as well as the diaphysis of the all phalanges, metacarpus, and radius and ulna. Usually the epiphysis and diaphysis should fuse by 14 to 16 years, but still, despite having a chronological age of 20 years, they were still not fused. So probably her bone age is less than 14 to 16 years. Even there was a non-ossification of the sesamoid bone as well as the hook of Hamage. Even they should be ossified by 14 to 16 years. So by doing this, we came to a conclusion that her bone age is less than 14 to 16 years. So since she improved both hemodynamically and clinically, we thought of discharging the patient. So since the cause was primary hypothyroidism, we ordered the patient to take the levothyroxine regularly at a dose of 75 micrograms per day. And we followed every month for initial 3 months. And during each month, we repeated the baseline investigations like serum lipid levels, anthropometry, T3 and T4. As per the TSH value, we adjusted the levothyroxine dose requirements once in every 6 to 8 weeks for the 3 months. At the end of 3 months, again, we subjected the patient for the repeat chest X-ray, which was found to be absolutely normal with no evidence of any reaccumulation of pericardial fluid. And even the 2D echo shows the no accumulation of any pericardial fluid. And her TSH value reduced drastically from more than 100 milli-internation units to 20 milli-internation units per ml. So it's at a glance. See, the first on the left-hand side, there is a X-ray which at the time of presentation of the patient show the typical water bottle configuration of this cardiomegaly. After 3 months, there was a drastic reduction in the size of the cardiomegaly with the normal cardiac borders. Again, this for the better view, like ECG at the time of presentation and immediately after pericardiocensis, you can see that there is a resolution of the electrical alternates, and there is also regaining of the normal QRS voltage, which is classically shows that the tamponade has been resolved. Now, what is the peculiarity of this case is that what is unusual is that cardiac tamponade as initial manifestation of primary hypothyroidism is extremely rare, though very few case reports have been reported. But what is common is that cardiac tamponade as well as the hypothyroidism as the individual entities, they occur in isolation, they are quite common. But cardiac tamponade as initial manifestation is quite rare. Now, once we seen the entire details of the case, coming to the discussion part, as you all know that hypothyroidism is still a widely prevalent problem worldwide with low T3, T4 and elevated TSH levels. And it is still very widely prevalent in the iodine deficient regions. The typical cardiovascular manifestations are the exercise intolerance as well as the dyspnea. The usual features with this the patient presence of bradycardia, diastolic hypertension, muffled heart sounds, cardiomegaly, and they can be both pitting as well as a non-pitting edema, depending on the duration of the hypothyroidism. So mild asymptomatic pericardial effusions are common in almost all cases, like 3 to 6% of the cases we do see pericardial effusion. That is not the actual the discussion today. The basic discussion of this or the main important point of this case is that massive pericardial effusion with cardiac tamponade as an initial manifestation in a newly diagnosed primary hypothyroidism is quite rare. And there was a few quite very less case reports have been reported even in the Western as well as the Indian literature. And all these manifestations of hypothyroidism are basically because of reduction in the metabolic activity and because of increased deposition of glycosaminoglycans. Now, what is the basic pathophysiology behind this X-ray type of pericardial effusion? There has been various hypotheses, but most important is it occurs mainly because of increased systemic capillary permeability and also because of disturbance in the electrolyte metabolism. These are quite new hypothesis, which explains that extravasation of albumin and inadequate lymphatic drainage from the pericardial sac are the two most important factors which contribute to the X-ray nature of the pericardial effusion. So what I mean to say from this case report is that very high degree of suspicion is very important, especially in the areas where the hypothyroidism is endemic, because it is a completely curable condition and the cardiac tamponade can be prevented from the recurrence. So to conclude my topic, I would like to mention that hypothyroidism is still a common and widely prevalent problem in India with approximate prevalence of 10.95%. Though pericardial effusion, tamponade secondary to thyroid dysfunction are very rare in the Western scenarios, in India, because of high burden of this primary hypothyroidism, we do see a lot of cases. So despite having the sophisticated diagnostic as well as the therapeutic modalities, always include primary hypothyroidism as one of the differential diagnosis of pericardial effusion and cardiac tamponade, especially in a country like India where hypothyroidism is still endemic. Now, why this case is unique and why this case has been accepted in the index journals is that the cardiac tamponade has a manifestation of primary hypothyroidism, especially in our case, like engage is very, very rare. And she had a peculiar dysmorphic features that which is mainly because of effect of thyroid hormone on the growth as well as the bone development. And she had a secondary dyslipidemia, which is also because of primary hypothyroidism. And it was reverted once we corrected these TSH levels. And cardiac tamponade in this case is completely curable as well as completely preventable. All these three features make this case a unique. So a very high index of suspicion and including primary hypothyroidism as one of the differential diagnosis of cardiac tamponade is very important, especially in countries like India. And this is our case report, which has been published in the European Journal of Cardiology, European Heart Journal case reports in the May 2020. With this, I'd like to conclude my case report, and I would like to thank STEMI organizers for giving me this opportunity. Thank you.